Jerry? Is that right? So our next speaker, we're going a little bit out of order because of some scheduling issues. Honored to have the Director of Pediatric Neurosurgery at Stanford and Lucille Packard, Dr. Jerry Grant, who is going to speak to us about endoscopy as an adjunct for tumors, vascular, and shunts, and maybe throw a couple other disorders in there, Jerry, if you can. But sounds like a panacea. Enlighten us, if you will, and we're okay. We'll move forward.
Yeah, we'll move forward.
Sorry, but I could see you, Ramin and Mark, so thank you for inviting me. And this is really an interesting panel. I think a really nice array of topics. And this topic, as you said, is a little bit hodgepodge. It's several things together, but it really is the same theme in how we use the endoscope to assist us with operations. And there's different kind of types of assists, and we'll go over that. We think about this sometimes for tumors. We think of it for vascular kind of cases, hydrocephalus, and I've used it for all these different circumstances, and we'll kind of go through those together. So if you think about, can you still see my slides okay, Ramin? Yeah. So there's endoscopic assist versus endoscopic controlled. And, one is really using the endoscope as an assist device, where we're basically under the microscope, under direct vision, doing a craniotomy. And we might use the endoscope to assist us in our visualization. And that's different from endoscopic controlled terminology, where we only have the endoscope. That would be an example of a pituitary transnasal case, for example. So they're really very different approaches, but of course the techniques are very similar. One thing that's technically important, is this sense that you really need a rigid endoscope holding arm of some sort. It's not something you want to be holding in there because it kind of takes your hand out of view. And when you're doing a microscopic case with an endoscopic assist, there's only so much room there to maneuver. And I really like to fixate these rigid scopes in this kind of setting, which you may not do in something like Ben was talking about, where you're doing very flexible type techniques. And then there's this rigid scope versus flexibility. And to be honest, I like more the rigid. I use different angled scopes in this kind of setting, particularly for getting underneath certain areas, looking around the corner. I worry about the flexible scope in these settings, how to get that flexible scope back out, and you can really cause damage. And this is something that we're always worried about, is getting in and getting out, I think, are the riskiest times for these scopes, especially under the microscope. Because if you think about it, you're looking under the microscope, and then you have your endoscopic screen. Unless you're somehow coupled together in a virtual environment, you can really be distracted and think you're beautifully going down to an area, but unfortunately you're causing a lot of destruction along the way, particularly the base of the frontal lobe, for example, or olfactory nerves, or optic chiasm, or carotid. These are areas that once you get beyond these structures, you won't see them. You can't see behind your scope. I think that's a critical point of any of these kind of endoscopic assist or controlled environments. Spatial awareness is critical to really be on top of that. And I'm essentially, when I'm putting the scope in, I'm using the microscope. I'm watching that scope go down. I'm not even paying attention to what the endoscopic screen is looking at. Once I'm down there, I fixate it, and then I can look around and do things and manipulate structures to look around corners or whatever I'm trying to do with these kind of scopes. So I think these are the important messages. I think the take-home points about safety and being very careful because of some of the problems I've seen of just inserting these kind of scopes into that area. Of course, you've discussed it. Probably Ted went over this, Mark, in terms of the transnasal approaches, and Jeff Greenfield too. These are classic approaches where essentially we've gone from microscope to endoscope. So it's a little different to think about using both. That's that assist approach, where we might go from below, and we might do certain cases, for example, like this. I'm not sure if you can see my cursor, like going transnasal, then coming back from above. In this area, paracellar area, clivus, there are areas that we'd love to get around the corner. We'd love to look under structures, especially coming from above. Whether you've done a low orbitotomy, an orbitozygomatic approach, You're always thinking about corridors, and clearly the lower we are, the higher we can look. And with the scope, we can even look higher. And that's, I think, the real advantage of these kind of rigid scopes, particularly those acute angles, the 70-degree angles are really nice. When I first go in, I mostly use the 0 degree, then I move up 30 and 70, because it gets even more challenging to think about where that scope is as you're looking up at or down at some of these structures. And then extended approaches, of course, you might use these different angles and use a combination of the microscope, especially if you've gone above and below in the same setting for a very wide, large cell or supercellular lesion. For example, you may need combined approaches. Case example of an 11-year-old with 3 or 4 weeks of headaches, nausea and vomiting, with a fundus examination showing papilledema. Here you can see the films. You can debate in this kind of setting, going from above, going from below. Is it age dependent? What if the sphenoid was ossified? What if this was a 2-year-old? How would you get to some of these structures? And of course, we're always thinking about going from below and transnasal for these. But say you had normal pituitary function, very young child, small nares, is that the best approach or not? If we go from above, losing vision, how are we going to get underneath the optic chiasm? How are we going to look through the lamina terminalis? How can we look up into that third ventricle? Really reproducing the same kind of view that we get transnasally, but doing this from a subfrontal or lateral subtemporal approach. And I've used these rigid endoscopes for some of these brainstem lesions, mesial temporal areas, quadrigeminal plate, coming from the back, coming from the side. It really gives you such beautiful optics with that rigid scope, particularly. I'm not willing so much to use the flexible because the optics is just so good in these rigid cameras. To get these kind of views that, I'm going to advance some of this because I know you've already talked about the transnasal approaches, but thinking about a cranio and, we're spoiled from below and that we're underneath these nerves, but think about being above and looking up at that chiasm in terms of how you would see those areas. And, we're always trying to get a complete resection if we're in there. We want to, if anything, look at these chiasm areas from underneath, because that's where we're going to cause the damage up in these tracts, particularly up near the chiasm tract junction. I think it's a very risky area. Things are distorted, but the scope then allows you to get just like the transnasal approach, but get underneath for some of these really complex lesions. We try to go back cranially from lesions that, we've already done some work from below, then sometimes later in a staged approach, we go from above. I think these are really nice techniques. Again, these corridors are really key in terms of preserving the stalk, preserving the chiasm, and these scopes, kind of like our mirror. In the old days, we used to use a swivel mirror. I don't know if any of you, or Mark or Rabin, use those mirrors, but they're really nice to look underneath. They do fog some. You have to be careful with that, but they are very safe to use. But that's, directly under the microscope, looking at these structures. The endoscope's even better. And, I learned this mostly from doing vascular. This is back when I was in the military, doing all these different vascular cases. And it was wonderful to take these scopes down because we always use these minimally invasive approaches to get down there. Similar case like this, where you can go transnasal, another craniopharyngioma cyst, calcified. You can look at these walls carefully. We've been able to look with the endoscope real nicely to figure out how to safely resect these. We're always worried about that hypothalamic portion. We're kind of pulling from below. We're just hoping it might come down in that capsule. From below, we're used to this, right, in terms of how we pull on these areas and in terms of removing this kind of thing. But doing this from above and pulling up into the hypothalamus, I think, is where we cause that risk. How wonderful would it be to actually see these under direct vision, see those interfaces, so as we pull, we kind of see exactly what that looks like, and we might leave these capsules. And, if anything, we become more conservative, right, over the years of how we handle the hypothalamic portion, these parts that go way up into that third ventricle. I've done some work with transciliary approaches where there's a series of about 120 or so we've done of approaches to the anterior cranial fossa. These are really nice corridors, and you can stay nice and low. We do a small orbitotomy, tiny bit of zygoma, all through that transciliary eyebrow incision. And this is a great approach where you'd want to think about using a rigid endoscope. The positioning, of course, on these, you're in quite a bit of an extension. You're doing a small orbitotomy to get extremely low to allow you to pass that endoscope. And I've done these either endoscopic controlled, remember that's primary endoscope, versus endoscopic assist, where we're using the endoscope to assist us to do various ACOMs or planum sphenoidal small craniopharyngiomas. Last week I did a transciliary approach for a pituitary thickened stalk, questionable germinoma in a kid with DI. Get a biopsy essentially because it was a question of inflammatory apophysitis, germinoma versus Langerhans. And this is a really nice way to stay nice and low and do these approaches. Use your endoscope to your advantage to look around these corners, look at the back of the stalk. I think it'd be very difficult open to do that without the scope because you essentially have to move the stalk away. You essentially be risking the chiasm, moving the anterior cerebral or the carotid laterally to try to get to these areas. So as you get more minimally invasive, as we think about this for our small corridors, or like we're doing now with the metrics approaches, where we use these small tubes in the brain to access these corridors. The endoscope is a beautiful way, again, to look around those areas because we have no retractors in. With these scopes, you can get nice and close, really close to comfort almost to these aneurysms, for example, or any lesion really around this paracellular anterior skull base. I think is a really nice approach for this region. So I would say it gives us a better view of some of these anatomic features. It's a very clear observation of these parent vessels, the branches. Very nice for some of these cranios going laterally as you're going down toward the basilar and the PCA, as well as the optic chiasm, of course, to get, again, underneath that chiasm. The 0 degree is great for that illumination even, just to get light at those deep areas. Sometimes our scopes don't have that capability to get in that deep hole. You're always thinking, can I be brighter? Can I be higher magnification? This will be interesting how this changes, of course, with some of the exoscopes and some of the synaptive, different kind of companies that are working on this, Olympus, Zeiss, et cetera, to think about how to get to these deep areas, get that lighting and magnification that right now we use these endoscopes for. And then these 30, 70 degree acute angles to really look around these corners that otherwise there's no way you could see unless you move these structures. So the more minimally invasive we get, it's going to become even more challenging to look at some of these structures to try to get a gross total remover of these tumors. Thinking about from an endoscopic assist point of view for shunts, this has been looked at over the years, and of course the different centers and collaborating in terms of looking at whether this makes a difference. There have been studies out on this. There is some level of evidence showing that potentially that there's a little higher infection risk using an endoscope for a primary shunt. Is that the right thing? Does somehow the placement of the tip of the catheter somehow improve the longevity and shunt function? This has been always a question over the years. I don't use this routinely for upfront shunts, but I have used it routinely for revisions. I think this is a really nice way to revise a shunt. We used a very small 1 millimeter scopes. You can use a disposable with a non-disposable. There's different ones out now. Storz has one we're looking at now that we've been using and trialing. I think this is a really nice area that instead of using, Brain Lab or Stealth or some other image guidance to get you to these areas, I follow that old tract. I look at these kind of cases where the shunt tract is so small, a typical slit ventricle kid where you're really challenged to think about how you're going to get a new catheter in. The catheter is blocked, but how are we going to revise this kind of catheter? I think these scopes are beautiful, in this setting. This I took through the ISPN has this really nice site, that looks at these different areas for pediatric neurosurgery and the ISPN guide that Rick Abbott's done over the years. And this is an example of the video that he's had in his portfolio that how we follow the tract. You essentially put that rigid scope down your tract of your old shunt. You can remove it that way. Sometimes the tip, of course, is stuck. You have to use the get back to the PowerPoint here. Use the Bugby technique to remove an old catheter.
Lewis is one of the
Sorry, I have to get rid of the.
Shown in the National Board of Review as one of the best pictures of
Can you
the
hear me
year.
okay?
Phantom Thread, rated R.
I want to get Jim Carrey out of here. 1 second. Are you with me still?
You're good.
Okay. So, and here's another view. So once you pop through that area where you've been able to advance that catheter, then you pop into the ventricle. Now you can look in there and you can decide if you want to fenestrate something or make 2 ventricles into 1, whatever you might want to be doing, of course, to advance this. But all in the setting of a really tiny slit ventricle, I think is really nice for these cases. So something to think about for these kind of problems where I've really been saved, where instead of removing that old catheter and trying to find a new tract, I think it's a really nice way to use this endoscope to assist, especially these tiny ones now that we can do 1 millimeter scopes that can keep the hole extremely small and revise some of these shunts where they can be very challenging if we can't get back in, for example. We always use that old tract, and without this kind of ability, we could essentially dissect into the white matter, really not know that we're safe. So we use these kind of assists. They're very complementary. We're always thinking about how to use that rigid scope with an open case to get us that better visualization. Most of this is for skull base. I would say rarely used in the, say, a routine medulla of the 4th ventricle, but you could do that if you were trying to look up into the aqueduct from the other way. You have to be so careful that, especially along the floor of the brainstem, you really need to be watching those scopes, watching first how you get that scope there, again, under the microscope, and then later using the endoscope screen to look at some of these areas. But always thinking about your spatial awareness of what's around you is critical. This is where your assistant can really help you, keep you safe as you're going in and out, which you really when you're going to cause that trouble. But it's allowed me, at least in my practice, to really be more aggressive in the skull base, intraventricular lesions, vascular lesions, shunt revisions. And, the future is this whole 3D scope technology, a lot of this augmented reality, a lot of this space now that we're always thinking about how could we be better in our optics and understand better that 3D relationship of some of these structures, which is critical for this rigid endoscopic assist approach. I think I'll stop there. Maybe if you have questions, we can address those, but I try to give you some highlights of different kinds of cases. Most likely craniopharyngiomas in the pediatric scope is what we'd be using these scopes for. I like the rigid more than flexible because of the optics, and I think the readily ability to change your 0 to 30 to 70 is they'll give you amazing views that if you haven't ever looked, I think you'd be surprised of what's around your corner. So thanks so much, Mark and Ramin. I really appreciate the opportunity to chat today.
Thanks, Jerry. That was wonderful. You mentioned something at the beginning that I'd like to bring up is the use of the scope itself as a tool, especially with the metal sheath that sometimes people can use for things like vascular and tumor, where you're using it as an adjunct. Have you ever found that sheath to be helpful, and how do you use that scope to sort of help with the adjunct part of the surgery? Obviously, you can't put an aneurysm clip down a scope. But what are some technical pearls that you can share with the audience for the use of the scope itself?
You talking about for assisting kind of cases, or?
Correct. Yes.
Yeah. So it's a really good question, Ramin. So I think from an assist perspective, where you're not primarily using the endoscope for your sole source of visualization, I've mostly used it purely as an optical device. You have to be careful. The only pearl that I've learned early on with these is, it can heat up at the end of that. And I don't want to be right up against the carotid, essentially, with that scope. I think there could be some problems. And you can see sometimes changes in the vasculature as you're right up against these areas. And if you put it against your hand, you realize how hot they get. So be very careful with the illumination in terms of, and keeping your distance from some of these areas, I think, is critical. I don't know what that distance is, but I think that is an important message. So I'm not essentially doing anything primarily with the rigid scopes as an endoscopic assist. I also don't use a sheath because you're essentially open. This is an assist device where you've done a craniotomy, and I don't think a sheath would help me in that regard. Definitely for endoscopic controlled cases in the brain, I like a sheath going in and out of the cortex. I think it's helpful. But be careful of the lighting, be careful of the heat. Keep your field wet, I think, is important. Keep it moist. You don't want to pass. I've also seen trouble passing a dry, very dry endoscope past, for example, some of these perforators where it can stick. And I think that you don't want anything to stick. You want that field moist. I always irrigate before I put these scopes in to keep everything nice and moist. I think that can be helpful.
Great. Well, thank you again. It was a wonderful talk.